Concerning intervention for obesity, we will speak about changing paradigms today. And the first paradigm that has changed is this one. On the left side, the largest man in the world in 1903, and on the right, a normal size of a policeman in the States today. The story goes back to 1954, when the first intestinal bypasses in humans were performed by two different groups, but both of them in Minneapolis, in Minnesota. And today, which is the surgical portfolio? We have restrictive bariatric surgery, like gastric banding or the sleeve gastrectomy. We have malabsorptive bariatric surgery, the biliopancreatic diversion and the jejunal-ileal bypass, which are quite abandoned today, and the mixed bariatric surgery, so restriction and malabsorption in combination, like the Roux-en-Y gastric bypass. The trend worldwide of bariatric surgeries has been modified in the last years, and you see an increase of the sleeve gastrectomy and stable use more or less of the Roux-en-Y gastric bypass, and the other techniques are much less common. So what can endoscopy do? We can try to copy what surgeons are doing since many years, and they are very effective. So we can have restrictive endoscopy procedures, like the space-occupying devices or the procedures that imply stitching of the stomach, like the sleeve gastroplasty, or the pouch restoration in patients that regain weight after Roux-en-Y gastric bypass. We can mimic surgery with malabsorptive endoscopy with the duodenal liners, so devices that allow the food not to touch the duodenal mucosa, and then a mixed bariatric endoscopy with the endoluminal bypass liner, which is still under evaluation. So in terms of risk and efficacy, of course, diet and exercise, the risk is very low, but the efficacy is also very low. Then we increase with surgery, and in the middle we will have endoscopy. The problem is that only 1 to 2% of the patients receive surgery. So there is a treatment gap between diet and surgery that can be at least partially filled by the endoscopic treatments. So, which are these endoscopic treatments? The space-occupying devices are mainly represented by balloons that are inflated inside the stomach. We have today two types of balloon, the balloons that need an endoscopic assistance to be placed and removed, but we have a new generation of balloon that can be swallowed, and they do not need endoscopy to be placed and also to be removed because they pass spontaneously into the intestine after 3 months. The problem is that with all these kind of devices, they are effective in the short term, but no one has been proven to be effective in the long term for a definitive loss of weight. So, and again, within the restrictive techniques, today we are able to suture endoscopically the intestine with different devices. The first one that was used was the Endosurgery, but the stitches were too superficial. Then there are other techniques that have been mostly abandoned, like the TOGA, the transoral gastroplastic technique, which was very interesting because this was the first endoscopic suturing device, a full thickness device, and but unfortunately it was abandoned. And now today we have what we call the endoscopic sleeve gastroplasty, that can be performed with two systems. The OverStitch endoscopic suturing system, produced by Apollo Endosurgery, and that needs double channel gastroscope to be used. But this was initially used to restore the anastomosis of Roux-en-Y gastric bypass in patients that regain weight before being used for primary endoscopic gastroplasty. So this is the technique. The technique includes the trauma with argon plasma coagulation of the tissue that we want to oppose, and then the passage of the Apollo OverStitch that is able to take full thickness suture of the, in this case, of the anastomosis, and in the case of gastroplasty of the whole gastric wall. And with one or multiple stitches, you'll be able to close this anastomosis and to reduce, if necessary, also the volume of the gastric remnant. So which are the results of this technique? There is a big series published a couple of years ago by Chris Thompson, and actually it is effective because you see the percentage of excess weight loss in this patient that had regained weight after Roux-en-Y gastric bypass was around 20% at 3 years. We also have some experience in Rome. We have now close to 50 patients. It's a very safe technique, and these are the results in terms of loss of weight. And then the endoscopic sleeve gastroplasty was developed with the same device, the Apollo OverStitch, but also with another device that has been developed in Brussels by the group of Jacques Devier. This is the Endomina. The first series, the feasibility study, was published last year in GIE on 11 patients. And this is the device which is, let's say, more flexible compared to the Apollo OverStitch because you can use all the types of gastroscope. You don't need a double channel. And the system is assembled inside the stomach, and the principle is the same. You catch tissue, and then with a needle, the stitches pass full thickness through the gastric wall, and by doing this several times, 4 or 5 times, you are able to reduce the gastric cavity and to create an endoscopic sleeve gastroplasty. This is the widely used OverStitch, Apollo OverStitch, the same. Today we start from the antrum and we place 4 or 5 stitches in order to create a gastroplasty and to leave the fundus free. The results of this multicenter study are very interesting, as you can see from this slide. They were presented 2 years ago at DDW. The total body weight loss is minus 20% at 1.5 years of follow-up. We also have started some experience at my hospital, and we are now planning a prospective study on this. So, other devices that had been used, this is the jejunal-ileal duodenal-jejunal bypass liner, the EndoBarrier, which was very promising. The only drawback is that, as all implantable devices, has to be removed. And the problem is that the study was stopped last year because of severe adverse events. And as far as I know, the company is now producing a new device with a less aggressive system to fix the device in the bulb. And finally, the aspiration therapy. This is quite awkward technique. However, it seems to be very effective. It implies the positioning of a PEG, of a percutaneous endoscopic gastrostomy, to remove the content of the stomach after a meal. So what the ancient Roman called the vomitorium. And of course, together with lifestyle modification, it helps to weight loss. It is inserted like a PEG pull technique, so very easy. These are the results of the US clinical study, and as you can see, there was, compared to a control group, there was a total body weight loss of 14% at 1 year, and an excess weight loss of 37%. This is due to two reasons, the caloric diversions, but also improving in heating behavior. So today we have a lot of possibilities. We still are trying to understand who qualifies for which kind of weight loss therapy. Probably what we can say today is that the overweight may profit from diet. The severely obese are surgical candidates, but there is a place also for endoscopic techniques in between. What is extremely important is to keep in mind that obesity is a metabolic disease, is not a diseased organ or tissue, and therefore understanding the pathways that regulate appetite and energy metabolism is the key to developing smarter treatments. And however, the key for success in this field is related to the multidisciplinary evaluation of patients with not only gastroenterologists, endoscopists, and surgeons, and endocrinologists, of course, but also psychiatrists. Thank you very much.